everyone, welcome to Bite Size Learning with MDSA. My name is Divya Sriramlu. I am the Academic and Research Officer of Malaysian Dental Students Association for the 2019 and 2020 tenure. Bite Size Learning with MDSA will be a new series of short, concise academic videos whereby we invite experts to cover clinical related topics and some common questions or challenges that students or dentists may face in their clinics. Today we have with us a very special guest, Dr. Shalini Kanagasingam. Dr. Shalini is currently a senior clinical lecturer and course lead for the Masters of Science and Masters of Clinical Dentistry in Endodontology programs at the University of Central Lancashire, United Kingdom. Welcome, Doctor, and thank you for being with us here today.
Hi, Divya. Thank you for having me today.
All right, without wasting any time, let's jump right into the topic of today, which is tips on managing pulp calcifications. I think, Doctor, you can start off by explaining to us what are pulp calcifications and maybe how they appear clinically and radiographically.
All right, thanks, Divya. So we know that pulp calcifications can occur in many forms. Sometimes it's like stone-like, sometimes it's just a diffuse layer covering sort of the canal orifices. And this is usually our body's reaction to irritation or injury. So dentine is laid down, but in a very haphazard manner. And I've listed a number of situations where you might find calcification. So this includes an aging or aged tooth, where you have periodontal disease, orthodontic treatment, and certainly bacterial infection as well. And I've put here, just to let you have a look radiographically. If you do a good pre-operative assessment, you'll be able to actually detect the calcification before you even actually open up the pulp chamber. So you can see the radiopacity, if you look at my cursor, within the pulp chamber, this one actually extending into the canal. And then you can see these little stone-like fragments, within the pulp chambers in this CBCT scan, for instance. And if you do open up a tooth and you find that, you actually can't actually find, you haven't dropped into pulp chamber firstly, and you actually can't even see the canal orifices. And if you see this type of, layer of dentine, which looks actually quite different from, sort of the wall dentine, you can tell that this is not the floor of the pulp as well, because if you are looking for the floor of the pulp, you can tell the color changes. On the right, for instance, you can see where this actually looks like a floor of the pulp chamber, where you will find your orifices, whereas on this clinical photograph, you can see that something is actually covering it, so stopping you from finding your actual canals.
All right, Doctor. So I think one thing that we should keep in mind while removing the calcification is we have to be conservative so that we don't remove too much of tooth structure. So what instruments would you recommend to safely remove the calcifications?
Very good question. So there are many ways to actually remove calcifications. I think traditionally you'll find that some clinicians might actually opt for using the high-speed burrs, which I find that's probably going to be high risk and more damaging to your pulpal floor, which you want to preserve as you're removing the calcifications. The other option I've put down, and even though I've crossed it out, is the long neck burr. Gooseneck burr comes in different sizes as well. Again, this can be an option. The only reason I'm crossing it is because I don't find it to be useful in my hands. So I'd recommend to you what I tend to use, which is ultrasonic tips. So I usually start off sort of new users or clinicians with the Start X tips. They are quite hardy tips, and they've got different designs for different uses. I do find that when you have this type of ultrasonic tip, it's actually quite easy, user-friendly for the clinician to position, to be able to have more control as to how much dentine or calcific dentine you're actually removing, and to make sure that, of course, in doing so, you don't damage the pulpal floor. And you can see the picture here. By having sort of the shape of the ultrasonic tip, placement in this way, you can actually visualize where you're placing it. So you are not going to risk removing, dentine in areas that you actually wanted to preserve. So I would go for ultrasonic tips. So here's an example of a case. You can see from the periapical radiograph, there's some calcific material within the pulp chamber. And as you remove the restoration, you can see that there is some sort of layer covering the pulpal floor. So here what I'm doing is I'm using the Start X tip, and what we're doing is we're just kind of going round, trying to go around to trace and almost cutting laterally rather than putting apical pressure, in trying to loosen this sort of calcific material. And if you can see, you can use your DG16 probe. A nice sharp DG16 probe will help you now flick out all those calcific material. Now you notice that I use the Start X tips dry, and most of the time, if it comes to these situations, I'm using only intermittently, so only short periods of time. You can have a look at the calcific material that's been removed there. So don't overheat, because you have to use dry so you can see what you're doing. The water will just, you know, make things very unclear to you as to where you're positioning. So once you removed all that, you can see that you can see the base of sort of the pulpal floor. Yeah. One tip about using these ultrasonic tips and using them dry is to also be very careful. If you use at high power and you use it over a long period of time, you can actually cause overheating and damage to the tooth. So make sure that you actually, you know, stop and irrigate in between. And of course, once you get your hypochlorite into the pulp chamber, you will see this bubbling effect, and the canal orifices will almost reveal themselves to you. Now, in terms of, now that you've actually revealed some of the canal orifices, how are you actually getting your file into it? Because sometimes even the sort of the coronal part of this orifice could have still some remaining calcific material blocking them off a little bit. So I have found that if I go back to my usual, if you look here, K files, you know, my usual small files that I introduced initially into the root canal, you will find that they will start to buckle. They've not got that rigidity to give you, you know, to be able to press into a canal. So a good option for you to consider is to maybe invest in some C+ files. You could have a just small set of these. These have been designed to be actually stiffer. And when you're doing sort of that watch winding motion, trying to get into sort of like a very tight canal at the coronal area, this C+ file actually is more effective. I would say to you though, because it is actually more rigid, you do not want to introduce this file deeper into the canal. You're only looking at the coronal section just to get through, yeah? Now, if you don't have C+ files, what you could do, and what I have been using also, is I'll go for a shorter, so 21mm K file, but maybe slightly larger sized, perhaps a size 15 or 20, to just get into the canal initially. And by using a shorter file as well, and you will get more of that tactile feedback, and you have more control. And because it's slightly larger in size, you will also not have that buckling effect like you've seen here. Now, this is another example of a case which you might commonly actually come across. At first glance, it might look like a very straightforward case, right? It's a lateral incisor. Most people will think single canal, I'm able to do it. But if you look closely at the periapical radiograph, you can see that you can see the canal sort of moving apically. But what happens is you can see the section where your pulp chamber and the coronal part of the canal should be is kind of fuzzy on the x-ray. Yeah, you can see that it's more radio opaque. So this shows you that you're already anticipating when you actually access this tooth. Look at what you find. It's actually solid. You've not got into the canal. So what you need to do then, you need to actually, under magnification, using the ultrasonics that I've described previously, you need to actually trough sort of intermittently. And what you would do is you keep removing dentine, but always staying centrally within the canal. And how do we know we're in the center? So don't use coronal tooth structure as a reference. The best reference point is really your CEJ. So if you kind of just be guided by your CEJ and you stay very central, you keep sort of troughing apically, because you know as soon as you get past that section that's calcified, you will drop into a canal. Now again, DG16, things like micro opener as well will help you with that troughing, and of course the ultrasonic tips, and working dry and irrigating in between. What you will find at the end, hopefully, is once you've removed all the calcific material, you will either find this sort of white center, you know, in a darkened area, or in this case, perhaps you see this whitish area surrounding a very darkened spot, maybe a sticky spot even, that you can feel once you actually use your K files into it to find that this is where your canal should be. Now, again, just to remind you, once you've actually gotten past that coronal section, because calcifications occur coronal to apical, you will most likely have a straightforward journey to the apex afterwards. Yeah. So it was only that section you needed to be very careful and make sure that you are constantly checking that you are remaining centered as you continue to trough with your ultrasonics. Right. So if we have done a proper pre-assessment of the radiograph, we would anticipate a case that is calcified. So in which case you may want to actually decide that you do not want to clamp the actual tooth. If you're isolating with rubber dam, you would place your clamp on an adjacent tooth. Now, this is because you may have to stop in between troughing when you're looking for the canal to take a radiograph, and you don't want that clamp to block off that view of that sort of cervical area of the tooth. You could also have an option of using a soft clamp, such as the Kerr soft clamp, which actually appears less radio opaque on the radiograph, so you'll be able to actually better visualize your file going into the canal. Another option is actually with anterior teeth, you could just actually place your rubber dam with wedges and not even use a clamp at all. So very quickly, we've gone through some of the tips for managing calcifications. We know how it occurs, coronal to apical. Magnification and good lighting is always very important in any part of dentistry, really, but especially when you're dealing with calcifications. We know that in trying to remove the calcification, we must not damage the pulpal floor to preserve the landmarks which show us where the canal orifices are. And as I've shown you, we use the ultrasonic tips dry so that you can see better, but only intermittently. Now, also by removing the restoration, it gives you sort of more access into the tooth and more light flooding in so you can see what you're dealing with. And I've mentioned to you some options of perhaps using C+ files. As soon as you got the coronal part of the tooth access, you need to go into coronal flaring and introduce irrigant as soon as possible. And of course, at the end of the day, if you can't manage to find it within that visit, you may decide to actually stop and close up and come back to the next appointment to actually deal with the tooth. If you continue on when you're tired, you're fatigued, you just risk making mistakes. So I would say, give it another visit to have another go.
All right, doctor, when would we consider that the case is not within our capability and we should refer the case to a specialist?
Divya, I think that's a very good question. I think we all have our own, we need to be aware of our own limitations as well. If we've tried really, hard, we've used whatever techniques and instruments we have on hand. And here I'm showing you an example of stopping to take an X-ray, to take a periapical radiograph with the file in hand, so you know exactly how far you've troughed. Are you troughing in the correct direction? Do you dare to go further? Anything beyond the CEJ, you really need to stop and think. Yeah. So, and I think it's fair enough. There are specialists, you can refer to an endodontist who has the use of microscope and additional materials to actually look for the canals. So I think it's a few questions I put down here for you to just think about before you consider troughing further deeper into the tooth to look for that sort of canal. And certainly please consider referral if you feel uncomfortable. And if you've explained this to the patient beforehand, you've explained to them the difficulty of the case, I think after you've attempted, it's fair enough for you to sit them up and say, in your best interest, I think I would like to refer your case on. And you've had a good go.
All right, thank you, doctor. With that, I think we have covered most of the important points or tips related to managing pulp calcifications. We hope the audience find this video informative and helpful. Thank you, doctor, for your knowledgeable inputs and sparing your time for us today.
Thanks, Divya.
Okay, with that, we have come to the conclusion of today's video. Thank you everyone for watching. See you all in the next episode of Bite-Sized Learning with MDSA. Subscribe to our YouTube channel and tune in for more of our videos. If you have a topic you think we should cover in our next videos, comment down below and hopefully we can cover those topics in the future. See you all, bye.